From the American Academy of Pediatrics.
Most children, adolescents, and young adults with complex medical needs receive care at home.
A new clinical report looks at the needs of these patients in the home environment and the transition between hospital and home.
It's our obligation, I think, as pediatricians to really try to optimize the care that we can deliver at home in a safe and high-quality manner.
Plus, new research emphasizes the importance of medical interpreters in hospital pediatrics.
The expectations of interpreters in hospital settings is quite significant, and the pace of their job is really high.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about home health care for children, adolescents, and young adults with complex medical needs.
I take care of a lot of babies who have complex medical needs. A good example, David, is babies who require a tracheostomy and a home ventilator.
I can imagine that it's a difficult decision for families to place a tracheostomy in their baby, but then you also have to help them make sure they can take care for that trach when they get home. How does your hospital train families to do that?
We have an at least 6-week training program families need to go through to take their baby home with a trach. And even if families complete the program, having a trach means a lot of follow-up and ultimately visits back to the hospital. It's hard. I always feel we need better community supports for these parents and their caregivers.
And we as pediatricians need a resource on how to care for children with medical complexity. So I'm glad the AAP has put one out. Today we're going to discuss the clinical report, Home Health Care of Children, Adolescents, and Young Adults with Complex Medical Needs. And we have lead author, Dr. Elaine Lin, with us.
Dr. Lin is a general pediatrician, assistant professor of pediatrics at Harvard Medical School, co-director of the Cerebral Palsy and Spasticity Center at Boston Children's Hospital, and chair of the section on home care at the AAP. She's interested in how we can be innovative about providing quality care to children with medical complexity at home. Dr. Lin, welcome to the show.
Thanks so much for having me.
So, Elaine, let's start by defining this issue of medical complexity. How big is this pediatric population, and what's the scope of their needs?
So the percentage of children with medical complexity differs based on definition because it varies a little bit between hospital to hospital or healthcare system to healthcare system. We estimate it's anywhere between 1 to 10% of all children. And the framework we often think about this population in is that they are kids who have substantial healthcare needs, multiple chronic conditions, often significant functional impairment, high technology use, as well as high healthcare utilization in general.
Can you give us a little bit of the history of home care for children with medical complexity? How have these children gone from mostly being cared for in the hospital or in an institution to being able to be at home with family?
In the early part of the 20th century, these children were often cared for in institutions or in congregate care settings. And then I think a lot of physicians really realized that that was not the ideal place for them to thrive. In 1967, with the creation of Medicaid and EPSDT, or the Early and Periodic Screening, Diagnostic, and Treatment Act, these children were provisioned to have services at home for the family to be able to care for them in that setting.
And what types of healthcare professionals make this sort of home care possible? I mean, there are so many people helping my patients that I know I never meet.
Yeah, in this clinical report, we really tried to define that in the first table because nothing really exists in the literature thus far. It's a wide range of nurses to personal care assistants to therapists that are all part of what we think of as home health care. In the report, we define, the different levels of providers as well as their competencies and skills. So again, it can range from a therapist who's delivering mental or behavioral health to a nurse who's doing high-level skilled nursing care in the home.
And when we talk about complex medical needs, we're talking about children who may need support for many organ systems. So how can pediatricians ensure families have the supplies and training that they're really going to need to care for these children, even when they have healthcare professionals supporting them in the home?
Yeah, in the report, we really emphasize when the patients are admitted, often if we're thinking about babies being sent home for the first time, that training is a huge part of the discharge planning, as well as coordination with the medical home. We really try to outline in the report sort of the organ systems that are involved potentially with children with medical complexity and to really to think through each one. And that training should happen on all levels, for all the caregivers who are going home with that patient. Coordination with the medical home is really important, and communication with the home healthcare agency, who's often providing the home care, is important so that everybody is on the same page and understands the nuances of that patient. Training on the equipment that the child's going to go home with is really important, and identifying the vendors or suppliers who are going to supply those things is really important. All of those things need to be carefully set up before going home. A lot of the vendors will do home visits beforehand to make sure that the environment is safe and able to take the equipment home that the children need.
And it's one thing to care for these patients' medical needs, but another to care for the emotional needs of the family around them. Do you have any tips on how we as pediatricians can be better attuned to how caring for a child with medical complexity shapes those family dynamics?
Yeah, I think it's really important to meet the family where they're at. So again, before discharge home, really understanding the psychosocial situation of what's going on at home. Who are the caregivers? Who are the family support systems? Who are the siblings potentially or other family that the caregivers need to help care for, and really understand how this child will kind of fit into all of that. All of our families, I think, want to take their children home and be in their communities. And so knowing what support networks the family have, both on a personal level as well as a community level, is really important.
And how much do these families rely on Medicaid to help access the care that they need?
Almost all the families need Medicaid. Many of the private insurances don't have home health care as a primary benefit. This is largely why the Katie Beckett waiver came about, in that, children who don't qualify by income to Medicaid qualify by disability to be able to access home health care services.
Elaine, how do you anticipate Medicaid cuts may affect these children?
I think there's a significant threat to home health care access, and that's going to be state by state dependent in terms of where the states are going to prioritize their budget. But home and community-based services are certainly something that we're keeping a close eye on, because they may be cut with the new changes with Medicaid.
And Joanna mentioned earlier that her hospital has a process for discharging these children into the community. Do all hospitals have something like that? And what should that process ideally include?
I think all hospitals should. I don't know that all hospitals do. I think that training the caregivers, again, is a very important part. There should be checklists of when a child goes home with a new tracheostomy or a new G-tube, of how many times the providers show the family, that the family does it themselves independently, and as much opportunity we have to give the families the autonomy to do it themselves and have the rest of us be there to support them and ask questions is ideal. Again, coordination with the medical home is really important, because that's a key piece to supporting the family once they've left the hospital doors. So making sure the primary care provider or the subspecialist who's going to be in charge of that new technology or specific care for that medical condition, and making sure that they know what family supports and services are in place, is really key too.
And for community pediatricians who are listening, what should they be asking for from the hospital before they assume care of these patients?
Having a very well planned out discharge summary is really important. The community pediatrician should definitely receive the discharge summary, and hopefully in that it outlines what equipment, what medications, what support services, what therapy and educational services are set up for the family, so that they're able to follow up on that in their initial visit.
Well, there's so much in this report, Dr. Lin. We could probably do more than one podcast on it. So our toughest question yet for you: what is one takeaway you want our listeners to know before they read your paper?
Children with medical complexity are a growing population, and I think no matter what specialty of pediatric care you're in, you will interface with this population. And it's important to know that although we think of them often in the hospital, the majority of their life and time is at home in their community with their families. And so it's our obligation, I think, as pediatricians, to really try to optimize the care that we can deliver at home in a safe and high-quality manner.
Well, Dr. Elaine Lin, thank you so much for joining us today.
Thank you for having me.
To read the paper, Home Health Care of Children, Adolescents, and Young Adults with Complex Medical Needs Clinical Report, visit our website at aap.org/podcast.
Coming up, we'll look at the role of medical interpreters in hospital pediatrics.
It's time for a check-in, David. How is your Haitian Creole coming?
I mean, you'd have to ask my patients, but I'm certainly getting opportunities to learn. Last week, our Haitian Creole-speaking families outnumbered our Spanish-speaking families 5-1. But there has been a major setback. We lost the interpreter on staff who was serving as my bedside tutor and cultural guide.
I know that our bedside interpreters are so valuable. There is one Mandingo interpreter I've worked with closely, and when I see him, I can't help but smile because he is lovely and funny, but also because he puts families at ease and makes my job more enjoyable. I don't speak any Mandingo, but I feel like I'm connecting with patients all the same.
And yet, I think sometimes we fail to include our interpreters as the valuable team members they can be. A new article in Pediatrics, We Don't Like to Be Invisible, the expert roles of medical interpreters in hospital pediatrics, explores this issue further. And today, we get to hear from two of the authors, Patricia Buzelli and Monica Vinasco-Sandford.
Patricia Buzelli has worked as a nurse practitioner in hematology and oncology, but currently she is a PhD candidate at the Duke University School of Nursing, where she is a recipient of the Duke University's Dean's Graduate Fellowship. Monica Vinasco-Sandford is the senior medical interpreter at Boston Children's Hospital and a member of the Ignite Consortium Parent and Guardian Advisory Board at Dana-Farber Cancer Institute. Patricia, Monica, welcome to the show.
Thank you for having us.
Thank you for having us. We're so excited to be here.
Absolutely.
Quick question to start. Does either of you have a favorite language?
To be spoken to?
Yeah.
Or to speak?
Or to speak?
Or to hear.
Oh, Italian to hear. Anything.
Oh, I love that. Patricia?
I mean, I'm going to be biased and say Portuguese, right? Grew up hearing it, listening to it, speaking it. Feels like home. It's home. So I'm going to be biased.
Oh, I love that. A language is home. It's a great way to start. Patricia, we've talked before on this podcast about some of the challenges non-English speaking families face in the hospital setting, but can you expand on that?
Sure. I think most people would agree that if your child is hospitalized, that in and of itself is a stressful experience, right? So your child is sick, you're relying on this complex medicalized system and world that's not familiar for most people to care for your child. Now, imagine that, but you also don't share a language with this medical system and the people within it. So for families who speak languages other than English, that just adds this whole other layer of complexity to this already really stressful situation. So some of the challenges that present themselves for these families are multifaceted and cascading. And it can include things like delays in receiving and accessing treatment because of the difficulties of navigating this care. It can present itself like language barriers that can cause miscommunication in clinical pictures and how they're presented to providers, and in turn, how treatment plans are created that align or don't with what's really happening. And that miscommunication can impact children and their families beyond the hospitalization into discharge planning and follow-up care, right? I think the effects of language barriers and miscommunication also extend into how mistrust is presented in these settings, or the processes of mistrust. How exactly? I'm not so sure, but I do think it plays a part in that. And I think all of these issues related to language barriers may be part of the reason why we see the statistics that children whose parents speak languages other than English have twice the odds of experiencing an adverse event when they're hospitalized, right? But I think it's also important to mention here that language barriers by themselves don't account for these issues alone. And I say this because in the work that I do with bereaved Latino parents, there's this concept that is related to, but not the same as language barriers, and something that I call cultural communication barriers, which is more about how communication is happening and less about what language it's happening in. And when these barriers are present, it can be quite detrimental to the care that the child and family is receiving, especially around prognostic communication, anticipatory guidance, decision-making, end-of-life care, and all the things that we as providers know are really important that we do well. Otherwise, we see really adverse effects for families later on.
I love that description of cultural barriers along with language. So thank you, Patricia, for that. And in my training, I learned that when you use an interpreter, you look at the patient and sort of pretend that the interpreter isn't there, even though they're the ones speaking. Monica, can you talk about that idea and how we can work to make our interpreters a more visible part of the care team?
Well, I have to say that as part of training as an interpreter, we are told and trained to be invisible. However, when you are actually on the field, and say on a field like Boston Children's, where most things are extremely complex, it's difficult to remain invisible, given that we also have a lot of questions for the providers about what is being said. We manage very complex diagnoses that may not be on any book insofar. So for that alone, we have to be able to speak up and clarify so that we can pass on that information to the family in as much as they can understand, because medicalese is totally different from English or Spanish or whatever other language. It's a language in itself.
Your article also brings up an issue that I have to confess I have given very little thought to, and that's the trauma experience of the interpreters themselves. How does that trauma occur, and what do you think we can do to help address it? Monica?
When does it occur? At any given point of an encounter. From the moment you enter the room, you may be coming into a room that visually is very challenging, like a trauma room. From that moment on, there is the visual trauma you are taking in, plus the conversations happening in a trauma room, which is everybody yelling at the same time. Now, when it is a more civilized encounter, we ask for a huddle before the actual visit so that we know what do we have at hand. Who is this kid? What brought him in? So we have an idea of what we are walking into, because that would be another source of trauma, walking into a patient's room and not knowing what you are there to help with. And after an encounter, we do appreciate providers stopping for 1 second to let us know how did that go. On occasion, and it happens more and more often where I work, are you okay? Was this okay with you? Because we are humans in the room where a lot of life-changing events are happening. So in order to, let's just say, avoid the trauma that comes with the job, we have been asking, at least where I work, please give me a preview of what we're walking into. And in the end, if there's something else I should know before I move on to my next case.
And Patricia, can you give us an example of what a preview might look like? Does it differ depending on the clinical severity of the patient?
Yeah, so my understanding of this as a provider who has intentionally sat with interpreters to capture this and understand this process is that the expectations of interpreters in hospital settings is quite significant, and the pace of their job is really high. The issue that I have heard from interpreters is that with each encounter, they require a different emotional presence. And the transitions between each encounter, because of the pace of their work, sort of jostles their effective response system and doesn't give them a lot of time to process or recover from the potentially difficult encounters they have, like end of life or the ER trauma ones that they have, for example. So my understanding is that all of that is further compounded by the fact that there's this bi-directional exchange of information that's emotionally charged that they're doing in the first person, which has come out as this concept that is heavy for them and wears down their ability to be able to bounce back and recover from these really difficult encounters over time. On top of that, these systems often don't support this process or their ability to find ways to process what is happening. And another thing that Monica and I have talked a lot about is that there's this inherent trauma that comes from getting to know patients and their families over time and then bearing witness to their decline and potential death. That's the really traumatic piece. And then being left to deal with that trauma alone.
And in this article, you give an example of a child who you call Kay, who reminds me of so many of the patients I care for in the NICU. Monica, can you talk about this case specifically and the role that interpreters played in the family's hospital experience?
So Kay came to Children's at 1 month of age. He was born at about 500 grams. He was a tiny thing, and he has been part of the Children's family ever since. He is now 6. He turned 6 in July. So this is to the extent that we follow a family. So his first almost 2 years of age, he was in the NICU and then moved on to an ICU unit. During this time, we would have to come and visit the family mostly daily for rounds, update of his condition, which at some points was very fragile. So we would be called stat. And this time you just come in running because he is having an episode in which he's nearly dying. I'm sorry. And sometimes they do call us stat, and we have to come in running because he was dying. That happened too many times for a little baby. Moving fast forward, he did a recovery that they didn't expect. So it was a wonderful development for us to see the family, to celebrate the christening of the patient, to celebrate his first birthday with all the staff in the ICU. So we know we became part of that family just by seeing them every day and having every other conversation and bearing witness, like Patricia says, to their ups and their downs. And at one point to the space and time where he had a massive brain injury from which they didn't think he would recover, which he hasn't, but he didn't die. So we're still walking the walk with this family. And it has changed a lot of the interpreters' lives where I work, because we have learned about courage and dignified living from the family. So that's also part of what we do. We learn from them.
That is a really profound story, and one I'm taking a moment to process.
You know, Monica and I have talked about this, and we talked a lot about this in writing this article. One thing that is really interesting, and I think speaks to the roles of interpreters that gets missed, is that today the interpreters are continuing to care for this family and follow this family's trajectory. And their role has shifted to, it's a teaching hospital that Kay is cared for at. And they are part of care continuity for Kay in that they teach the new residents and the emerging physicians about Kay and Kay's journey and teach how to take care of Kay alongside the family. And I think that is a really interesting and important role that is not always captured or operationalized well in how we care for families as providers. We don't leverage our interpreters as we should.
Well, it sounds from that story and others like there is a lot of room for improvement in this area. What would you like to see hospitals and programs do to more fully integrate medical interpreters into the healthcare team? Patricia?
Yeah, you know, I think it's important to make note here that we understand different hospitals have different resources and capacities, and we tried to kind of make note of that in our article as well. And so it may be hard to do all these big shifts that we're proposing, and we want to be mindful of that. But I also think there's a lot of different ways that hospitals and programs can make meaningful movements to integrating interpreters. And that can be a lot of different things, like giving interpreters a little bit more autonomy over their schedule and creating buffers around difficult encounters and or buffers to allow for being present in rounds or debriefs, pre-briefs, whatever that may be. And also mean giving interpreters role-specific access to EHRs that isn't standard across hospitals, which is something that we've learned. And that might be really important, especially when navigating medically complex children or end-of-life situations. Other things we'd like to see is that hospitals, providers within them, and programs believe that interpreters actually work within these roles and are able to provide care in these roles. I think that's the big key here that maybe we got across and maybe we didn't. I think that might be up for debate, but we need people to believe that interpreters are all of these things and then shift the power to interpreters to be able to enact those roles as assets to the care that we provide.
I mean, you got so much across in this article. Everyone should go read it. But before they do, can you each think of one takeaway for our listeners? Patricia, let's start with you.
You know, I think the reason we chose this for our title was because it was so impactful to me when Monica said it, was they are not invisible. They are part of our team and we need to do better. So interpreters are not invisible. That's my takeaway.
Monica, do you have one for us as well?
I think beyond not being invisible, to be considered part of the medical team that takes care of the patient and the family, to feel they can ask us because we do have pertinent information to the care of this patient that for some reason you may not be on the notes. A lot of anecdotal information is powerful information. So bring us in.
Well, we want to thank you for coming in and sharing so much information with us today. Patricia Buzelli and Monica Vinasco-Sandford, thank you so much for talking with us.
Thank you. Pleasure to be here.
Thank you.
To read the article, We Don't Like to Be Invisible, the Expert Roles of Medical Interpreters in Hospital Pediatrics, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, this one is really simple. We had a couple of our newborn nurses who delivered just a few days apart, and I was there to take care of one of the babies, and then I was off service and never got to meet the other newborn that I was so excited about and so excited for her mom. But her mom brought her by the hospital a couple of days ago while I was there, and I got to hold her and take pictures of her, and she's now 2 months old and absolutely beautiful. So I loved that chance to catch up and see this baby that we had all been anticipating so much.
Oh, I love a Say Ah that's about babies. Thanks for that, David. And my Say Ah is about my first cousin, Adam. He lives in Seattle, and I know you're going to be moving there soon, David. And we just hadn't had a chance to see each other in years. But we just had a recent visit where we got all of our 6 kids together, and it was crazy and so fun. And I'm just so grateful for family and for the ability to see family that live far away.
I love when you get all the cousins together because it's always a little crazy. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss the management of food allergies in schools.
We'll talk to the author of a new clinical report, Dr. Scott Sitcherer. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.